kick things off because the slide's not going. Here we go. All right, so just a little bit about myself first. I'm married to a general dentist. This is Matt Bynum, my husband. We met in dental school and we practice together. We practice in the same building. He is a high-end cosmetic dentist. He does all on X, he does all the things. And this is for the one time I actually have a cool piece of technology that he does not have, and that rarely happens. So again, this is Matt. We practice together. This is our boys. This is Matthew, Luke, and John, and our dogs. They're also boys. So I am the queen. There's no princesses running around here. And here's all of us together. Just to give you some references that, like, yes, I do. I'm just not a person that does webinars for New Smile. I actually have a life outside of that. So this is our oldest son, Matthew. He lives in Florida. He works for HubSpot. This is his girlfriend, Maddie. No, they are not married. They are like professional models and they do wedding shoots. I've seen them in more tuxedos than I saw at, Ruth's Chris last week before prom. I mean, I saw so many tuxedos there. So this is their standard attire when they do photo shoots, and they're making a living at that. And then this is Luke. I don't know why his other photo didn't show up, but Luke and Faith down in the bottom there. He's a D1 at MUSC in dental school. He sent a text on Monday that said he had a practical on number 3. Everyone will appreciate this. He had a practical on number 3 in that mannequin head thing. And he sent us a text that said, I made that practical my bitch. So he seems to be doing just fine in dental school right now. And that's his girlfriend, Faith. She's a nurse. And this is John. John is a sophomore at Clemson. Matthew went to Alabama. Luke played football at Furman. Matthew is a sophomore, or John is a sophomore at Clemson. And this is his girlfriend, Sal. She plays rugby. And this is their trip to France over Christmas break while I was here working. There's Luke. He finally popped up. We're only working on mannequins. I don't know why we have to be dressed like, like COVID times are back, but I guess that's dental school, right? All right, so this is my practice, our practice. Matt's is at the top, Bynum Aesthetic. I'm Holly Trepito. And then some of you know me already because I do teach and lecture on tongue tie and airway, and I run a tongue tie practice out of my office. And that keeps me busy and keeps me learning. I love to learn. And that's why I think this piece of technology that New Smile Tech has for us has really called my name. This is my associate, soon to be partner, Dr. Megan. And she is like me 2.0. She gets me. She is the future face of the practice. And I just love doing work with her every single day. And this is our team. Obviously, we all know we can't do anything we do in a vacuum. We have to have an amazing team and culture to move the needle. And this is Maria. Maria just started with us in August, and they are just, this is my work family, and they're just super fun. This was her gender reveal. She had a little boy. Megan and I fought in the pool, and I won because she had a little boy. And then this is Bassem Nashed. Bassem is, unfortunately, he is in Turkey and Egypt this week. And he starts in our practice next week. His wife is also a pediatric dentist, and she's also coming to the area. She actually shadowed in my practice when she was in high school. So we do have some history with this couple, and just really excited to see the practice grow. And all 4 of these doctors, I want you to know, are Bassem's kind of shaking in his boots because we're not going to even let him use a traditional syringe when he gets there. He's excited about it, but we're not even going to let him pull them out because we packed them all away and they're in sterilization. So nobody in the practice, none of us use a traditional syringe anymore. We all use a sew-in. So let's get back on topic here. We're going to talk about these electronic anesthesia devices tonight. And I just want you to know that this all started with a company called Dental High Tech out of France. They have 26 years of experience with dental anesthesia. It's probably even more than that now. They've given more than 10 million injections, around the globe. They've presented this material in over 30 countries. The United States is late to the party because of FDA approval. So for us, it's a whole new world, but it's been around in the world for many, 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 many years. There's over 10,000 practitioners who are trained in this technique and technology. There's KOLs and lecturers all over the globe, and there's training courses available everywhere. And like I said, we're just very fortunate that New Smile had the had the wherewithal and took the risk and jumped in and did everything possible to bring this technology to the United States and to pediatric dentists in particular. So these are the head key opinion leaders right here at the top, on the top row. And then if you look at the smaller lines down, these are the other countries that do have KOLs and trainers that go around the world teaching this. Some of you on this webinar tonight have probably had the pleasure of either meeting Dr. Andrew Prinn in person or having him comment or reach out. You've reached out to him or he's reached out to you if you have a sew-in in your possession. He is the GOAT of all of this. That is who trained me. He came to South Carolina and trained my office. And then this is what you're dealing with in the United States now. You have myself and you have Dr. Loree Johnson, and we are literally at your service. You'll have my cell phone number. You can email me. You can DM me. I want to help you. I want to help you be successful with this technology. These are all the countries. The colors mean nothing. These are all the countries where the technology, where these devices are being used, and now the United States is colored in there. Canada has had it for a good while now, actually. And this is the marriage right here. So Dental High Tech, again, is out of France, and now New Smile has collaborated with them to bring this technology to the United States. And this is kind of how, dentistry started. I remember when I graduated from dental school, it wasn't 95 years ago, it feels like it, but when I graduated dental school, I mean, you could go in like thrift shops and antique shops, and you could find this kind of stuff still around, and some of it still worked. And this isn't what we have today. We have, things that are cleansable and streamlined and sterile looking and pretty. So that, that is really evolved through the years. And, just a lot of technology, a lot of new things coming down the pipe since we've been in school. And for some of you, new G's on here, you're going to see a lot more come in your professional life as well. But then we've got this. You could go to a market or a thrift shop and dig through all the tools and supplies, and the things that people buy to fix, radios and televisions and all that. And you could probably find a syringe like this, even at a, at a flea market or something, because they just haven't changed. There's been really no workaround to do away from the traditional local anesthetic syringe. So how this all came about was, dun, 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 in France, in the city that I cannot pronounce, there was a dentist, Alain Vignette, and he wanted to see patients not be in pain. And he was an entrepreneur and a forward thinker, and he tried really hard to figure out how to get a tooth numb while making the patient comfortable without making the whole face numb. And he worked harder and harder and harder trying to find the placement of the needle and just all the ways that he could make his patients more comfortable. And he finally came up with the idea that he needs to direct the needle to the apex of the tooth. So then again, how are we going to do that? And he invented a device called the injecteur. And this was a device that, one of the first devices to deliver a IO injection, an intraosseous injection. And then he passed it on to his son, the idea onto his son, who is also a dentist. And he was like, okay, Dad, let's take this to the next level, let's make this more modern. And through the years, that's exactly what they've done. And in 1997, they developed a company called Dental High Tech. By 2002, they'd made the unit even more, up to date at that time for 2002. And then they came out with these cool needles that we're going to talk about later that really has almost a lot to do with the success of the device and your techniques. And in 2007, you can see down at the bottom, Dental High Tech started to grow and they started to scale and become more profitable. And they came up with even a better unit, a more up-to-date unit in 2007. By 2011, they had introduced the foot pedal model, and Dental High Tech again is getting bigger and growing and getting more out in the market. By 2017, this is what they came up with, the Sleeper 1.5, which is what we call the Sleeper 1 now. And this is pretty similar to the model that we have available now. And this is what it looks like. It's the Sleeper 1.5, but we just really call it the Sleeper 1. And this is, so just to be clear, before I go any further, there are two devices that you can buy. You can either buy this device or you can buy the sew-in. They do the exact same thing. It just is what is preferable in your hands. And I'm going to kind of talk about why you would maybe want one or over the other. And this is what the sew-in looks like. The major differences, the sleeper one has a cord attached to it and the sew-in does not. The sew-in is portable, but whether you're taking the sew-in or you're taking the sleeper one, you have to take the rheostat with you. You can't go into another room and use a different rheostat. So that foot pedal is coming with you everywhere that you go. I personally have the sew-in. I had to make a choice back last year when I got my units, and I chose the sew-in for my two reasons were I don't like cords. I don't like cords on anything. Like right now I have a cord for the computer and my lights. I'm like trapped in this space with cords right now. I don't like cords at all. So I wanted things to look cleaner in the operatories. But the other reason for me was kids are rascals, man. And I can just see like a kid jerking that cord, and all of a sudden the sleeper one's like in the floor, or the needles in, the assistant's hand or something. So just for me, those were my two deciding factors. But again, I have lots of friends who have the sleeper one and they absolutely love it. And they're like, you're being silly. It's totally fine. All right, let me pull this up a little bit. So now we don't have to use this old equipment. Now we have these two things available to us. And this is a great slide here because I can show you the differences here. And this is one thing that people, this could be a deciding factor for you if you're deciding which type of unit to buy. If you see both of these units, you can see there's a light, right? Like on the sleeper one, right at the base of it where the cord is, there's a blue light, and that light goes all the way circumferential around that unit. If you look at the sew-in, that whole top flat row is a bunch of lights, and they light up and they flash, and they tell you different things throughout the use of the device, but they're only on one side. So the light is really the way that you communicate with the unit, or one of the major ways you communicate with the unit. If you have the sleeper one, you can see the light. If you're hanging upside down on your toes, you can see the light. You can see what's going on. If you're using the sew-in, sometimes the way the device is positioned, that light is away from you, and you're relying on the assistant to say, hey, is the light flashing? Or you're having to look at the plunger a little bit more discriminately and make sure that the anesthetic is actually flowing. So again, that is one difference that people are like, well, I definitely, I want to be able to see like what's going on with this light thing all the time. All right, so these are the things we're going to cover tonight. We're going to breeze through them here. The first topic, anesthesia and pain. I mean, that's the whole point of having this device, right? Is to eliminate this, literally get rid of people's pain points, the patient and ours. All right, people, let's see if I can get this volume. Let's just all pray this volume works here.
Plain jazz.
Plain jazz.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkare at 9:30.
Fire off.
Fire off.
Open door.
Door open. Så ska vi sätta en till.
Ja. Open door.
Run voice command.
Open door.
Run voice command.
Open door.
Repeat that.
Open door.
I didn't understand that.
Open door.
Play on the floor.
On the floor.
Error.
Area with a rock. Open door.
Classic, right? So good. Now, granted, those aren't the things we're dealing with anesthesia, but we have our own set of problems when we're numbing children, don't we? So first of all, we're dealing with the fear, and we're dealing with the pain, and we're dealing with the parents. I think we've all had it where we've had the kid in the chair and the parent is the one like being squeamish and has to turn their, I have in our practice in our operatories, parents don't come in the operatories. We have a viewing window and I can kind of see them out of my peripheral vision, and I'll go to give the injection and the parent is like pacing, or they have to turn around. They can't even watch, right? Sometimes it's more painful for the parent than it even is for their child. So for the patient, the things, that are uncomfortable and we're trying to avoid, it hurts when that needle goes into the gums. It hurts and burns because we don't have control of the delivery of the anesthetic in the traditional injection system. Are we numb? Have we got the patient numb? Are we sure, right? Are we really sure? Sometimes we don't know. Nerves innervate differently. Sometimes we are second guessing ourselves. And then this is really what we're dealing with more. So is the lip biting and the postoperative discomfort. And then, everyone associates, even having to call our office with the 4-letter word of pain. So let's give ourselves the opportunity to change a lot of that, because when our patient is stressed, that stresses us out. If we have a parent watching us and the very first thing we're going to do with their child is give that injection, and their kid, it hurts their kid, or the parent perceives it hurts their kid, I mean, we're going downhill from there. So what's amazing about this technology, it gives ourselves the opportunity to give a pain-free injection that's going to reduce the stress of the patient and the parent. It's immediate anesthetic. This is going to reduce our stress because we know, done properly, we're going to have profound anesthesia immediately. And it is always effective once you get the technique down. I think that is one of the, as a teacher and trainer of this technology, is, we have lived the life of delayed gratification, right? When all of our friends were buying their houses and their BMWs, we were like looking at our student loan payments and going, oh my God. So we're at the point now where we want things to happen quickly. And this is new. This is new technology. It takes a while for us to learn it. I'm still learning it and perfecting my techniques as well. So, it's just going to take a while. Your first round of these injections isn't going to be your best. So again, always effective once we get all the training in, and this is going to reduce our stress. And what isn't brought up on here is this then reduces the stress of our parents as well, especially once you've used this on one sibling, and then you have to either bring that child back for more dentistry or bring another sibling back. The parents are like, think nothing. I know exactly how well this visit is going to go. And no side effects. Again, decreasing all the stress. But then we wouldn't need this, would we? All right. So again, fear, pain, and then collateral numbness. And this is the thing that we're all really trying to avoid, is the phone call from the emergency room doc that tells us that an allergy panel needs to be run because the patient is allergic to Novocaine, which is, we all know, is just complete garbage. This is patients who have, chewed on their lips because they have collateral numbness. And avoiding these phone calls, avoiding kids that are hurting, avoiding parents that are upset with us is the goal. Having to give supplemental injections. This is literally a one and done, like literally a one and done. You're injecting them. It's 2 injections in 1 injection site, but you're not, going all around the tooth. There's no palatal injections. Granted, I have not given a palatal injection since dental school when you had to do it to like pass your stuff. But, some people, that is on their menu still, and they're doing that. But I've managed to get by without it. But again, this is a technique you're never going to have to give one again if you do give them and you don't like giving them, because I know your patients don't like getting them. So for the dentist, the things that it helps with, it's going to decrease that inefficiency that we have. It's definitely going to increase the behavior management, not of us, but of our patients. We definitely have more control of the patient's movement because this is not uncomfortable at all. And if you watch the techniques, granted, in pediatric dentistry, we are way more intimate with our patient than general dentists are. When I go on my husband's side, he's got loops that are like 100x or whatever, and he's like sitting all up straight and doing all this and doesn't have any back issues. But in pediatric dentistry, for the most part, it is a physical sport, and we are, we're all down around our patient. And when we're giving these injections, it is with the Soin or the Sleeper One, we are very close and intimate with our patients while we're using this tool. Because granted, I don't give injections like this photo is. Usually when you pull photos, they don't really know what they're showing here, but that's like a Gaugates or something. I don't know what that is. But the point of it is our fulcrum and our hands any type of injection we're giving with a traditional syringe are so far away from the target, right? Like our fulcrum is crazy here, and we just don't have the control of the tool that we're using because our hand has to be at the end of that plunger. And then it's also a strain on our own hands. Granted, I don't have any of these problems, but I've had plenty of people say that, not only is the hand piece going to destroy their hearing, but giving injections all day and aspirating is really tearing up their hands, at least a part of it. And then the other thing this is really going to help with is it's going to decrease your amount of appointments. And you can think about this any way you want. You can think about this as, wow, this is really helping my patient and I'm getting more dentistry done so they don't have to come back and be nervous or scared or miss school, and mom and dad don't have to miss work. Or you can do the math on this and you can say, wow, this is really going to help my bottom line. I'm going to get 2 or 3 quadrants done instead of just 1. And again, reducing stress. And I literally just got off an AAPD board meeting call, and one of the things that was discussed was the level of stress that our members are describing and talking about. And I don't know if it's just more okay to talk about these things now, or if there is legit more stress going on in all of our lives. I would say it's probably more stress going on in all of our lives. So anything we can do to reduce that, I think is super helpful and advantageous. So number 2, the goal is to hit the target every single time. And that is going to take practice, and it's going to take jumping on webinars like this. It's going to take realizing you're not perfect and reaching out and asking for help. It's going to take putting your other syringes in the drawer and making yourself use this. And if there's one slide I want you to really put to memory tonight, it is this slide, because these are the 4 ways you're going to be successful with this technology. Use the most appropriate anesthetic solution. Make sure you use the right amount of it. Be gentle and patient, which we are not as pediatric dentists most of the time, or at least I'm not, and inject close to the target. If you can dial those 4 things in, you will be more successful faster. So where do we say we want to hit the apex? That's our goal. That's what we're thinking about the whole time that we are. Once, Stanley Malamed says, once that needle passes through the gingiva, we're all giving a blind injection. All of us are. It doesn't matter if it's an infiltration, inferior alveolar, we're all giving a blind injection. No one can see beyond that mucosa. So you need to be thinking about where you've got that needle aimed and what your target is. And the target is the apex, because that's where that nerve is going to innervate that tooth. All right, number 3, the concept of this anesthesia. The coolest thing about it, and yes, we have lots of other devices on the market that can deliver optimized injection speeds. So this is just this is a device that does that. And if you have used any of those other devices, you'll know that if you can optimize the injection speed, it reduces the amount of discomfort that your patient has. So that's the first thing that happens. And then by controlling that speed, you're getting better potentiation of those vasoconstrictors. It's not hitting them and they're not freaking out. They're able to do their job better as that anesthetic hits them equally, which is way more comfortable and efficient for the patient. So this is kind of what it looks like when you're giving a normal injection and you're not able to control the speed and you're blind to what's going on beyond the passage of the needle. It sort of just like dissipates everywhere, and those vasoconstrictors really don't get a chance to do their job. Whereas when you're using electric control of anesthesia, this is more what we're shooting for. It's slow and steady. It creates a nice bubble around the area. So again, just showing you that instead of having to have your fulcrum so far back in a normal traditional syringe, you are up close and personal with this patient, and your hand, you're holding this device like a pen. And you can see that fulcrum is right there on those lower incisors. So how does it work? This is a great video to watch. I'm going to kind of describe it first so you know what to be looking for, but this is showing you the double injection technique. So the first injection that's going to go in on this video is where your goal of this first injection is just to numb that papilla. because your second injection, you're going to be going through that papilla, through that mucosa to deliver your IO injection. So your first injection is just to watch a little circle of the tissue blanch right there. You're not doing this for very long, 10 seconds probably max. Then you pull that needle out because you're going to redirect and come in a different angulation for your IO portion of the injection. And here we go. First injection. Bing, bing, bing. Second injection, different angle, because now we're trying to get down, we're getting that needle down past the, trying to get down to the apex of the tooth. So we're going through the cortical plate and that and here delivers our bolus of anesthetic. And this is a great place for the video to end, because one of the things that we all get hit with is I think they were numb everywhere else. I think they had numbness in other places. And what can happen right there is, instead of getting straight between those teeth, somehow you get off your angle and you end up in the PDL, which isn't hard to do, right? That's only a couple millimeters either direction right there. You could be in the PDL very quickly and very easily. So it just takes practice. You got to really work on your technique and reach out for others who are ahead of you in this. Another important slide and thing to know is when you're injecting in the maxilla, you can confidently know that you're going to get anesthesia 2 teeth forward and 2 teeth back. I will tell you, if you're dealing with a younger patient with more porous bone, you can push that envelope. You're probably getting more profound anesthesia because it can travel further, right? But just to know, if you just want to be sure, 2 teeth forward, 2 teeth back. And when we go down to the mandible, the course of action flows mesially. So we're going to only get 1 tooth distal and 2 teeth forward with our anesthetic. I know it shows 3 here, but you can confidently know that you're getting it at least to the molar and the premolar right there. So just to be thinking, when you're planning out your cases, you need to plan out what teeth you're working on, what is the extent of the treatment you're going to be doing on those teeth, what's the age of your patient, what's the bone like in your patient, right? Be looking back at your x-rays, be mindful of the size and gender of your patient, right? Like a 14-year-old football player is going to be a lot harder to get numb than a 4-year-old little girl, right? So when I first saw this lecture given at Bourbon and Baby Teeth last year, this was the slide that got me. I was half paying attention in the back of the room because bourbon, but this is the slide that got me. Oh, this isn't the slide that got, it's coming. They show this first. This is how you do it. 1 tooth back, 2 teeth forward. It's coming. So again, it's a 3-stage technique. You're numbing the mucosal first so that tissue is nice and numb so that it's not uncomfortable for your second injection. Then step 2 is you're going to penetrate through that bone. And step 3 is you're going to deliver your IO anesthetic delivery. This video is going to show you, there's a foot pedal. We're not getting into all the training and all that tonight. Everyone can figure all that out. We're all, we all got like these, lots of degrees, lots of letters behind our name. So figuring out the device and the foot pedal and all the buttons and all that, you'll get there, I promise. But what I want you to appreciate in this video is this is for your first injection, and it's that middle portion of the foot pedal that's going to deliver this part. And you can see it's just, a drip. And what you want to do is you want to start that drip right before you enter into the patient's mouth, so it does start to numb the outside of the tissue. And this is also a great slide to point out that you see that letter D on there. That letter D is going to be on every single needle, Effitech needle that you use. And that D needs to be pointing buccally at all times, because the D lines up with the bevel of the needle. And to get the appropriate, to get the needle to go in appropriately without causing discomfort, you have to do it at that angle. And that's what that D is there to tell you to do. So you can see the D laying out, and you can see they're just kind of laying it into the tissue. and the tissue starts to blanch. Part 1. I think we can all do that. Or doing it already probably if you already have our units. Then we're going to pop through the bone and deliver the anesthetic. So this is showing you the speed of how fast that anesthetic is moving and the constant pace when we're delivering the IO injection. Again, same patient. And see how they are like straight up and down. Coming in and just imagining that there's no tissue there and, trying to go in the position they need to go. So I want to talk about this for a minute because as as it makes sense, if you've given IOs in school, in dental school, or just in your practices with a more robust needle or some other device that delivers an IO, you got to puncture through that bone and you'll often feel that happening. Well, these are the two sensations that people describe. It feels like that needle is like puncturing through an eggshell or puncturing through like a Capri Sun or a milk carton. But I want to tell you that that's not the litmus test of confidence. That if that does happen, you're like, I'm golden. I know that's good. But if it doesn't happen, if you don't hear the pop or you don't tactily feel that pop, and you've got that needle buried and you've got like you always want to leave about a millimeter to the hub showing just so you can orient yourself. As long as you're in, that pop isn't, that's not the end all be all. There's lots of times where I don't hear it, but I'm confident enough. I've done it enough times now that I know I'm in the right position. And when I step on the foot pedal, I'm not meeting resistance and everything's good to go. This is the slide I was trying to talk about earlier. This slide came up and I saw them inject into the papilla between E and F. And they said that you would have profound numbness from the canine to the canine, and you could work or extract or do Zerks or whatever you needed to do. And I was just like, this is sorcery right here, just sorcery. And literally until I had it in my hands, I thought it was sorcery. And now I've probably done half a dozen traumas where either traumas or where, the kid's too young for sedation yet, and we've got to get rid of D, E, F, and G. And again, talking about those earlier slides of decreasing my stress, I do not stress at all anymore going in to see a little one, knowing that I'm going to be able to numb them, make them comfortable, and get those front teeth out. So again, you should get profound anesthetic all the way from canine to canine. Same thing down here on the bottom. So these are just some pictures and some videos of showing some other practitioners using the devices. This is actually in another country, so the device does look a little bit different. It has a metal casing around it, but it is, for all intents and purposes, the same device. And you can just see, how close the hands are to the patient. She's using a mirror to retract so she can see what's up. Again, very intimate and close to the patient. And these are mucosal injections here. They're just numbing the papilla at this point. And then those would be the IO portions. You can see, I think you can appreciate how the unit is almost like standing up straight, if you will, when you're trying to go through that septal bone. Okay, these are two videos. The first video is going to be showing you the mucosal portion. The second video is going to be showing you the IO portion. I'm going to turn the volume down because they are speaking. Dr. Alp speaks the language I don't speak, so I am going to attempt to turn the volume down here for you when you watch this.
You think it? Mm-hmm.
And then we've got this one go. And one thing that's really great that helps you deliver the needle through the bone is that twisting. Just get real comfortable twisting to help trephine that needle into the bone. And see how patient, man, that's a lot of patience. I had to really work on my patience using these devices. I'm going to go to the next slide. They are in and going. again, just show, oh, this is my patient. This is in our practice. And just showing you that, you know, we have that thing straight up and down. I think this is a video here.
It's for fun.
The only time the kid blinks her eyes is when we put the freaking light in it. Other than that, she could care less what we're doing in there. Another patient. I love this video because if you look at the little girl's eyes, again, you can, I mean, sometimes the blink is the first sign that a patient is feeling, you know, some noxious stimuli, and nothing. I could make you watch that whole video and she doesn't move. She doesn't care. Super still and good. I'm going to play this one because this is in my practice. This is Dr. Megan and this is Jessica and Sean. And man, it is, I mean, I love being a pediatric dentist and we have fun and act like just morons every single day, but this has just made dentistry that much more fun. So this is Dr. Megan with a patient. I want you to watch the dance move that busts out. Right? That's fun. That makes coming to work fun because God knows we deal with enough BS during the day. All right, so planning out the cases, the first thing I would tell you is if you don't have the devices yet, or you're just getting them, like I said, let's not put the robust 14-year-old down as our first patient just because he has good behavior. Let's start with someone in the primary dentition with very cancellous porous bone. That's a really good patient. That is your starting point. And a lot of people, if you've looked in some of the forums and on IPEDO, and if you've joined the Facebook group yet for the Sewing and the Sleeper One, if you do IV sedation or go do GA, great patients to practice on. Great patients to practice on. Like, you know, not a moving target at all. And no one's judging you while you're, do I have the angle right? Does this look right? So you can really, you know, decrease your sweat volume if you're practicing it on a sleeping patient. So again, planning out the cases, here's a pano, and this is something that we've gotten a lot better at is I want to see, sometimes I'll say, hey, pull up a, you know, I don't want to see the bite wing, pull up a pano. I want to see like what my bone availability is. And obviously we don't have a lot of good bone around the two teeth that we know we're going to do those occlusal filling. I mean, that we know we're going to extract right there. So where are we going to go? We're going to go distal. We've got a great chunk of bone right there. And we know on the lowers, we can go 1 tooth distal and 2 teeth mesial for profound anesthesia. Looks like that permanent molar needs some work done on it anyways. And the coolest thing, which I haven't mentioned yet, but many of you already know, is as soon as you put the device down, you pick up your elevator, or you pick up your handpiece, or you pick up whatever you're going to pick up and you go to town. You don't have to go check. You can go check 3 hygiene if you want, but you don't have to. You can start right away working on the patient. So here would be an example where I know it's an adult PA. Again, we're not starting on someone like this, but you would look at this and be like, oh man, there's no bone between those 2 molars. That's probably not where I should go. But if you pull up the pano, you can see it's just a, you know, it's just a poorly angled x-ray, and you've got plenty of bone between those teeth to work with. Again, you're looking at these very discriminately, like where am I going to inject? And the examples would be there's some bone right there. And then I think like we talked about, you've got some bone right here, distal to the E. Some more x-rays. We've got a lot of work to do here. And again, this is just going to give you examples of, you know, where you want to be injecting when you're working on these patients and where your anesthetic is going to flow to. Another thing that may be a question that's coming in, Jordan and Chris, that maybe I can just say right now is the D is only critical for the first injection. The D only has to do with the bevel of the needle for that mucosal injection. When you're giving the IO injection, spin that thing any way you want. The D has nothing to do with that second injection that you're giving. Another thing that is different about this is I've always been a lidocaine girl. I think that's just probably what my dental school purchased. And so that's what I purchased when I got out. And this is a device that and a technique you want to use septicane for. Septicane and articaine are the same thing. And the reason is that septicane is going to penetrate the bone better than lidocaine will. And this is what we want to use. So here's a 4-year-old. We're going to do some work on K. And we gave a quarter carpule and we got the job done. Here's another one. We're going to give half a carpule and we're going to do some zerks here on these front teeth and get all that done. Some restorations. We're going between these two teeth right here. We're giving half a carpule. I mean, you're going to figure it out. You're going to figure it out like how much anesthetic you feel like you need to get the job done. Less is always more, in my opinion. But when you're first starting out, I mean, pump your patients. Like give them more than you think they need so that you have the confidence to know that they have profound anesthesia. I love this video because this is a hot tooth. You can see it's abscessed. It's very swollen. It's got some cellulitis going on. And I want you to watch them numb the patient and then literally pick up the elevator and like dig this pus-filled tooth out and like bear down on the palatal. And again, the tricky thing here would be finding bones. So assuming they've looked at an x-ray and they have said, I've got some good bone, distal to where this soupy mess is, and they're going in there. Popped in. People are like, how long does it take? I mean, it's about a minute. It's about a minute and a half to give that injection. Oh, hi, palatal. I don't even know what that tool is. I don't use that. Just going right after it, numbed and going right after that tooth right there. That's amazing. That is giving your patients exceptional care. Okay, this video, this is a really bad patient. This is me. I had a temporary crown on number 3 for a really long time, and I didn't bother to let my husband mess with it until it finally fell off one day. And so in between, we had an IV sedation day, and in between patients, I said, Megan, will you numb me with the sewing and then let Matt pop this crown off? It had already fallen off and it was super sensitive. So I was like, oh, I know it's going to need to be numb. So I was like, come over here and numb me real quick and then let him like glue this crown on in between patients. So Megan comes over, she numbs me, Matt rips the temporary off, scraping on it, water, you don't care about me. And I didn't feel a thing, but I want you to watch her give this injection. She's working for it. I'm an adult. I'm not a 4-year-old with cancellous bone. This took her a while. I want you to know I felt absolutely nothing, like nothing. When I went back and watched this video, I was like, okay, you're a little aggressive with me, but I didn't feel any of it. And you can see she's got the tactile. Now she's making me bleed. Right, because I didn't floss. I don't know what's going on right there. But you're going to see it pop in. Watch. Wait, there. It popped right in. And then she knew. And then she stepped on the foot pedal and we went away. We did it. So, and I was numb. That was number 3. I was numb all the way to number 10. Now, would I want you prepping veneers on my front teeth? Probably not. It probably wasn't that profound of anesthetic, but I was numb all the way to the midline of my palate. And when I tapped on number 10, it felt dead to me. And my skin, my cheeks, my mucosa, nothing else was numb. And really until you've had it done on yourself to go, that's like a real thing. All right, so how to be pain-free. We're going to use a special needle, which we've kind of already talked about. We're going to deliver the anesthetic electronically at a steady pace. And we're going to make sure we've got our, our ergonomics down, that we've got a good, I can't think of the word right now. Cheers to that. You got to get a good, purchase point or be able to, a fulcrum. You got to have a fulcrum. That was the word I was looking for. So this is what a standard needle looks like. And if you look at it under an SEM, it's literally tearing into the tissue. That's what a close-up of the end of a beveled standard needle looks like. And this is what the proprietary Effitech needle looks like. It's a double beveled needle, and it literally acts more like a scalpel blade and just sort of like melts into the tissue when you lay it on there. People ask, do you use topical with this? You don't have to. You can go straight for it without topical. The reason that in our practice we've chosen to stick with it is sticking a Q-tip on a kid's gums and watching them flip out is a pretty good sign of how the rest of the 30-minute visit's going to go. So we sort of use it more as a testing ground to see, you know, what we're dealing with the patient. But you do not have to use topical. You can go straight to town. All right. And again, like I was saying, you're just like laying it on there at about a 15-degree angle. I mean, no one's like measuring this. You don't know what you're doing. But you're trying to just like, you know, gently lay it onto the tissue and let it embed and soak in. And that's, I think the next slide's going to show you, like, you're not going very far into the mucosa at all. You're not trying to hit something, or it's just once you know you've got that, the portion where the anesthetic is going to come out of below the tissue, you're in the right spot. This is giving a manual injection. We think we're good. I've had people say, well, I give a great injection. I'm sure you do give a great injection. I'd like to think I give a great injection too, but I don't give injections like this machine does. So this is the way that the normal device works. And when we're, you know, hitting the high levels, that's where the discomfort comes because the pressure and the acid builds up. Whereas if we're using a machine that injects electronically, it's controlling that pace for us. This, not so much. This, much, much better. Again, having your fulcrums, using a pen grip, getting your depth right. I mean, there's a lot that's going to go into this to make you successful, but you can all do it. I'm convinced of that. These are 3 like variables involved to get better success. You want to be as close to the tooth that you're treating as possible for your injection site. You want to give the appropriate amount of anesthetic. Obviously, the further away you are from the tooth or teeth that need to be treated, obviously the more anesthetic you would need to give. And then obviously your vasoconstrictor plays a role in all this as well. You got 1 to 200,000 and 1 to 100,000 available to you. All right, so onset of anesthetic is immediate. If you're using 1 to 200,000, which is what is recommended, you're going to get 30 to 45 minutes of working time with, you know, with kids. I mean, we're losing them at 30 minutes anyway. So like who's doing a bunch of op past this amount of time probably anyways, right? So this would be what we would recommend using. And then if you do need a longer working time, you can go 1 to 100,000. Another time that 1 to 100,000 is maybe more appropriate would be like a tooth with a hypoplasia on it, or you've got a hot tooth and you really just want that anesthetic more concentrated and to have a longer working time. I'm not going to read this to you, but, you know, one of the things we get kickback on is like, oh, you can't give, you know, and I don't even know where all this got started, but you can't give a Septicaine or Articaine to a kid under age 4. If you've ever sat in any of Malamed's classes, he's got article after article, scientifically proven that is just hooey, and it is actually a better choice. No one's, you know, giving toxicity to kids under age 4 by using Articaine and Septicaine. So the next thing is, like, with any piece of technology, how is this going to affect our practices? And I would tell you, all it does is it increases your flexibility. And by that, I mean, you can go check a patient, or you can stay right in that room and get your treatment done. It's whatever your schedule looks like at that moment. You now have more control of, I'll just stay right here and get this MO and DO done and get out of this room in 7 minutes and let the assistant turn it over. And the next treatment's already here. We can start them early. Or, oh my gosh, I can maybe get 2 quadrants done today, right? So it's increasing your flexibility, and it gets you sort of thinking out of the box. Sleeper 1 or sewing, totally up to you. And here's some final thoughts. Let's see, how are we doing here on time? Oh, we're so good. All right, some final thoughts from me. just kind of a mixed bag. It is a big learning curve. And I will tell you that when I got it, I didn't have that big of a learning curve. I don't know why. Probably, I mean, Andrew was like an amazing in-person teacher for me. And we probably did 15 or 20 kids that day between me and my 2 associates. And I was also like so scared, all these people talking about bending needles and all this stuff. I was like, oh my God, I don't want to be that person. But you know, you're going to have your thing that you're going to struggle with. And you're going to, I mean, I've had a couple where I'm like, I'm just not really convinced that kid was numb. I think maybe they did feel that, and that tears my heart out. I don't like that. So there are things that are going to come up, and this is one of the things I already talked about, topical anesthetic, whether you choose to use it or not. Like I said, we like to use it to, you know, get a reading on the child's behavior. One question that gets asked for all you old schoolers out there, can you put a rubber dam clamp on immediately? Yes, you can. You don't have to give any palatal or lingual anesthetic. You can put your clamp on right after you've numbed the patient with the IO. And bending needles. I would say this is probably one of the bigger things that comes up. You're never going to really break a needle. That is very, very rare to have happen. But if you did break a needle, you can see it. You're not bearing it to the hub. So if the needle broke, the place that's going to break is right at the hub. So you're going to have like a millimeter of it sticking out. So what are you going to do? You're going to get your forceps or your hemostats, and you're just going to pull the needle out. I've never had it happen. Plus, you're also, because you are so intimate and focused and you're close to the patient when you're doing this, you're going to either see or feel that needle start to bend. You can sometimes feel it in your hand, and sometimes you can see it starting to like do this, and you're like, oh, it's bending. You either need to back up, you need to reposition, and sometimes you need to change the needle altogether because you have messed with the integrity of of the needle. And then, like I said, breaking needles. It's just, this is not something we're getting called about. Like, no one's like breaking needles into the gum and the bone. I want to just throw this out there. I just added this slide today because I saw this on IPEDO today, and then I also saw it in the sewing group today. And I don't want, and I also know that New Smile doesn't want to run from this either. I don't want to spend a lot of time on this, and I'm not trying to be negative against any other technology or device, because that's not who New Smile is. They're not here to like poo-poo or, you know, talk negative about anybody. The reason I put it in here is for an educational reason. There's been some posts talking about how you can get this unit because it is less money. You can buy this unit instead, and it does the exact same thing. This unit may look similar, but this unit does not do the exact same thing. If you look at their manual, if you look at everything on their website, this unit is not meant for intraosseous injections. Even if you buy the Super Pen, which is a more souped up version of it, it is not meant for intraosseous injections. Nowhere do they say you should use it that way, and you shouldn't use it that way, because the device that we're talking about tonight is made for that, so that you don't get ischemia and you don't have problems. So I would just say, if you're trying to save money, I was telling somebody this today, if you're trying to save money on gloves, save money on Post-it notes. Don't save money on some device that's going to deliver, you know, medication into the bone of one of your patients. And it's called the woodpecker. I just put that up there. Everyone's like, why do you have a woodpecker up there? Because that is the name of this device/company. One thing that is super cool, one of the things that does give my stomach lining a ride is dealing with a hypoplastic 6 or 12-year-old molar. And what's really nice is that if you infiltrate around one of these teeth, you're going to get, not many of us are infiltrating, but if you did infiltrate, you're going to get it numb 25% of the time. Whereas if you give an IO injection, you're getting it numb 88.9% of the time. Now, if I'm using a traditional syringe and I'm using septo and I'm shooting from every angle I can think of and giving the highest amounts I can think of, I still sometimes can't get that patient numb, right? Like, I know I'm not the only one on here. It gives me anxiety about the whole thing. And now when I walk into a room, and if it says like occlusal on 19, and it's, I don't care anymore if it looks like a, you know, a little tiny pit that I don't have to numb at all, or if it looks like some huge hole on 19, I'm confident that I can get profound anesthesia on that patient now. So again, the benefits, no discomfort. We're not chewing our lips. We're not getting called by the ER doctors with some nonsense. Appointments are shorter, and it really benefits our patients. And then for us, we can work immediately. Things are much more predictable. Remember, I talked about the hypoplastic molars. There's no delay between delivery and getting started right away if you want. Less stress for us. No post-op side effects. I want to talk about that for a minute because I have read some things on that. And I think that the people are saying like their patients were sore the next day when they called to check on them. And that I think is mostly for the people who are just starting to use the device and they're literally poking around in there and they're trying to get it right and they're going in a couple times or they're not really sure of themselves, because some of those same people who said their patients were having those issues aren't having those issues anymore. So I think it could just be sore because you're in there like messing around a little bit more than you need to be once you get your learning curve down here. We're optimizing appointments. And I mean, you want to talk about something that will market your practice all by itself. Like, don't hide this light under a bushel. Make sure your parents are knowing what you're doing. Another reason you want your parents to know this, I think it was Laree that shared, she had a patient or a resident that was delivering the anesthetic with the device, and the parent was pissed because he couldn't understand why it was taking so long. Like, why were you leaving a needle in my daughter's gum for so long? So there is some role playing and some scripting and some language that needs to be introduced into your practice. Your pre-ops and your post-ops are going to look a little bit different once you start using these devices, or they should look different once you start using them. So getting down to the end here, this is no longer going to be an issue. We're not going to need to ever give inferior alveolar injections again.
So Papa, you come to train.
Yep, that's about it right there. So no more of that, no more palatals, no more of that nonsense. So in conclusion, I think we can all agree that we have really taken a giant step forward with this technology. It is here now for us to use. If I haven't convinced you, there's tons of advantages. You've either been playing on your phone or sleeping through this whole webinar just to get the CE credits, which, by the way, am I going to get some CE credits for doing these? Can I turn in a certificate, please? Game changer, that is the word. If you read all these comments and stuff on on social media, it is true. It is definitely changing the game of pediatric dentistry. And the coolest thing is it's a trifecta. It's helping your patients and the parents, it's helping you, and it's helping your business in so many ways. So I love my job. I love the people I work with. This is Dr. Prin back here. This was on our training day. This is Dr. Maria. 3 thumbs up right there in that picture. These are both on training day. And we did I host a study club, or our city hosts a study club that I put together, and I had Dr. Prin lecture to everybody, and we had like an in-person stab lab. We all have licenses in South Carolina, so this was perfectly legal for us to be practicing and playing with the devices. We met last night. Again, 20 pediatric dentists from the upstate were in attendance last night at our meeting, and over half the room purchased the device. And I said, first thing I said, who got it? Over half the room raised their hand. I said, how's everybody liking it? Everybody's like, oh my God. So I know the other people in that room were like, I gotta get it. And actually I have 2 of them. In full disclosure, like, getting a demo is taking a long time because this is like a hot ticket, right? Like, everybody wants the demos and they only have so many. So I've turned it into like a demo center. So Matt DeHar already had it for 2 weeks. And then last night when we were there, another pediatric dentist said, hey, can I just like take one of them for a couple days? He's an associate, so their practice hasn't bought it yet. And I'm like, yeah, sure, fine. So I'm all about like doing anything I can to get this in people's hands, because I just want to see it, I want to see all boats get lifted with this technology. So we had a little bit of fun that night. I just want to leave you with a couple things here. This is a new Facebook group, the Sew and Sleeper One user group, and this is run by New Smile and New Smile Tech. And they want you commenting in here. They don't want you like in here, like blowing it up. And it's the best thing ever. This is a great, safe place to ask questions and post comments and And, we should put your wins in here too, so people can see like, I'm going to get it. It's, it is going to work out. Again, this is Dr. Andrew Prin. Back here in the background, this is Chris Malzone. He was the one that was speaking at the beginning of the webinar tonight. This is his information. We also have Jordan on the call tonight as well. I don't have a picture with Jordan because we haven't taken one together yet. We're going to need to do that in Toronto, sir. But this is all their information. If you'd like to take a screenshot of that, they are just as accessible, if not more accessible than I am. They want to see you succeed. They want to get this technology in your hands. They are extremely hands-on and very kind all hours of and all days of the week to help you learn all of this. There's Chris right there. I'll put this in here because this just happened yesterday. I got this post here, the picture of the box with the sewing, and it said, looky what came. So I have another friend who just got theirs yesterday. She's super excited. And then I just got a text from Dr. Gila today. This is her associate, Dr. Sabina. Their unit just came in. I think you're probably both on this call tonight, I would believe. So I'm very excited for that. Look, she's smiling already. She doesn't even have it out of the box, and she's super excited to be using it. So I cannot wait. I hope all of you reach out to me. This is Dr. Jeanette. I don't have her picture on there, but McLean's, she wouldn't mind me saying that. She got her unit, so she's super excited to try it out. So I just love to see my friends and my colleagues, jumping on this. Bobby, one of my dearest friends, colleagues, I adore to pieces. When he got, and let me tell you, he's a hard sell, man. He does not like change at all. Hey, someone working overtime today like a boss. I took out this tooth on a 13-year-old, did CNH on a 7-year-old, easy peasy. I'm pumped. Parents are blown away. He wrote this to me and Larry. He's like, thank you so much for your help. Larry's like, great job. And I'm like, I love hearing stories like this. So please hit me up with your problems, but hit me up with your, with your wins too. That's super important. Dr. Brian Richards, another great and dear friend of mine. Again, hard to break out of the mold. Didn't want to get one. Didn't see the value in it. Just did my first case. Some broken lower incisors. They were very sensitive. He couldn't even blow air on them. He gave one injection with a half a carpule of septo. Kid didn't flinch. He started beveling right away. Never felt a thing. Thanks, Dan, for selling me on this. We'll be curious how appointments go tomorrow. And the next day he was like doing pulps and crowns on 3- and 4-year-olds. He doesn't even use nitrous in his practice. He's a unicorn, I say. Some of you know Dr. Meredith Papadilla, one of my dearest friends. I loved getting this from her. Again, she was terrified. She finally took it out of the box and used it. I did it. I numbed at 10:13 and I had the teeth out at 10:15. He didn't even move. That's a 2-minute appointment, people. I said, can I please put this on the webinar? This was like 2 webinars ago. I said, we are so proud of you. And this is the line, people, right here. Thanks. It was a huge rush. Like, yay. Dentistry can be fun and new and exciting. What did I say halfway through here? We're all stressed out. We all can't, burn out, work-life balance, all the things, right? All anxiety, stress, all the things. And here's somebody saying like, fun and exciting. What we're doing is fun and exciting again. So you've got a great support team. You've got me right here in your back pocket. This is my my digital business card. If you scan it, it'll give you all my information besides my bank account numbers. And I want you to reach out. I want to help you. I want to see you be successful. I want this in every pediatric dentist's hand in the country, because this is what we need in our profession right now.